Hello, my name is Dallas Holliday. I am a fourth year emergency medicine resident with the Department of Emergency Medicine at Midwestern University. And today we are going to be talking about ultrasound in your toxicologic and poisoned patients. Now, I know what you're thinking. Ultrasound for tox, how can this be? But trust me, we're not going to be talking about ultrasounding for pills in the stomach, especially since this has been disproven in a number of studies. What we are going to be doing is focusing on high yield ultrasound for your poisoned patients. So here are some objectives. We want to recognize the clinical importance of bedside ultrasound in the suspected tox patient. And we want to understand the toxicologic ultrasound in shock and hypotension, or TUSH protocol. So let's go ahead and talk about our first case. So this is a 47-year-old male, was brought in by EMS after his family found him unresponsive at home. His wife notes that he has been depressed after losing his job about 6 months prior. EMS found several partially empty prescription bottles with the labels torn off around the patient. Unfortunately, we know how common this is with our tox cases, that they frequently present with very little information and unclear cause. So as far as past medical history, he has type 2 diabetes, hypertension, and congestive heart failure. His medications include metformin, verapamil, furosemide, multivitamin, and hydrocodone. So on this slide right away, if those were his prescription bottles, we've got some very concerning medications such as verapamil for calcium channel blocker overdose, hydrocodone for an opiate overdose, or potentially metformin for a lactic acidosis and overdose. So as far as his physical exam, his vitals are blood pressure of 77/40, heart rate of 58, normal temperature, and he's saturating appropriately. He's withdrawing to painful stimuli, but is otherwise unresponsive. Pupils are equal and reactive to light. He's bradycardic with no murmurs or gallops or rubs, and his lungs are clear bilaterally to auscultation. So this exam is somewhat concerning because the patient is hypotensive and he's also a little bradycardic. Is this because he's therapeutic on his calcium channel blocker and he's volume depleted? Or is he a calcium channel blocker OD? Or is this something more to do with opiate overdose? Certainly his pupils don't necessarily lend itself to an opiate overdose, but again, he could be a mixed picture. But the treatments for these are certainly quite different. We wouldn't expect a calcium channel blocker overdose to respond to fluids, and we certainly wouldn't expect hypovolemic shock to respond to insulin, the treatment of choice for calcium channel blocker overdose. In fact, that can be a vasodilator, which could be detrimental in hypovolemic shock. Additionally, his exam is revealing some decreased mental status, which could again be due to opiate overdose. It could also be due to calcium channel blocker overdose or some sort of metabolic or mixed picture. So what the heck do we do? Is this opiates? Is it calcium channel blocker? Is it sepsis? Is it hypovolemic? How do we know? So how can we tell what his hypotension is coming from? Luckily, we have something to save the day, the toxicologic ultrasound in shock and hypotension, or as it is lovingly called, the TUSH exam. So the toxicologic ultrasound in hypotension and shock is an adaptation of the RUSH exam proposed by Dr. Gasau, a toxicologist here in Chicago. The exam utilizes a two-step approach, or the twin cheeks of TUSH, as Dr. Gasau has coined. Basically, though, step 1 involves checking heart contractility, i.e. checking the pump. Step 2 involves checking the volume status, i.e. checking the tank. These should both be relatively familiar exams for experienced ultrasonographers and emergency medicine residents, but we're going to go through exam technique and emphasize why this exam is useful in your poisoned patients. So first, we check the pump. This is accomplished by assessing left ventricular function. We will do this by examining the parasternal long view of the heart. This exam is easiest with the phased array or cardiac probe, but the curvilinear probe will certainly work in a pinch. We'll be placing the probe in the third or fourth intercostal space on the left near the sternum, with the probe marker pointed towards the patient's left hip. And this is demonstrated there in that image right there on the right. Once we get our view of the left ventricle, we'll assess for contractility. Is the ventricle normal? Is it hyperdynamic? Is contractility decreased? So this is essentially what you're going to be seeing. So we're going to take a closer look at the anatomy of this parasternal long view. As this image details, you'll see the left ventricle on the left side of the image, and the aortic valve is going to be found just to the right of that left ventricle, and the left atrium will be slightly inferior and to the right. The hypoechoic region above the left ventricle is the right atrium, and this is really going to be the optimal view for assessing left ventricular function, and you can see by the anatomical drawing there that really you're catching a nice cross-section of the left ventricle. It's going to be really a great view for assessing whether the left ventricle is doing its job. And again, just here's another nice ultrasound picture of that left ventricle, right ventricle, left atrium, and aortic valve. So again, this is the view you really want to catch. So this is a lovely image from the fantastic people at 5 Minute Sono. But here's a parasternal long axis view, and this is demonstrating normal ventricular function. If this view were to demonstrate a dilated ventricle with poor squeeze, it may suggest a cardiac cause for the patient's hypotension and shock. But if you see this lovely contracting ventricle, then start looking elsewhere. Again, there you go, left ventricle, aortic valve, and your mitral valve, and your left atrium. So poisonings with decreased contractility, there are a few, the two primary culprits being beta blocker and calcium channel blocker overdose. So back to our case 1, our OD patient with evidence of shock and hypotension. Rapid cardiac ultrasound at the bedside revealed significantly reduced contractility, and the patient was treated with high-dose IV insulin for presumed calcium channel blocker toxicity with judicious fluid management. His heart rate and blood pressure responded, and you did not fluid overload the patient because you didn't immediately slam them with fluids for hypovolemic shock. Awesome job. Let's go ahead and talk about case 2. This is a 64-year-old female presenting for evaluation after she developed nausea and vomiting at home and admitted to taking 7 to 8 handfuls of enteric-coated aspirin, maybe about 3 hours prior to arrival. So we all know aspirin toxicity is dangerous, but let's hear a little bit more about her history first. She has a past medical history of depression, hypertension, type 2 diabetes, and she is taking metformin, fluoxetine, nifedipine, and lisinopril at home. Naturally, we always need to suspect poly-ingestion, especially since an OD of fluoxetine or nifedipine or both could also be dangerous in addition to the aspirin. So as far as her examined vitals, heart rate of 78, blood pressure is a little hypotensive, 83/61. She's a little tachypnic with a respiratory rate of 22, which certainly lends itself to an aspirin overdose. 99% on room air, normothermic. She's in a little bit of distress with her, nausea and vomiting, but otherwise pupils are equal and reactive. Her lungs are clear, heart's regular rate and rhythm, no murmurs. Her abdomen is soft. So again, we're presented with an apparently poisoned patient with shock and hypotension. Of course, we have this reported history of the aspirin overdose, but is this all related to aspirin volume depletion, or was there co-ingestion of a calcium channel blocker? We know that cardiac ultrasound can help us answer that question, but what about the tank? We know aspirin overdoses tend to be volume depleted, but pulmonary edema is also a serious complication of aspirin overdose. Can the tush exam help us monitor volume status? And as you might guess, since we're about to talk about it, yes, the toxicologic ultrasound in shock and hypotension can help us monitor volume status. Again, remember this is an adaptation of the Rush exam. So remember our twin cheek approach, and step 2 is check the tank. We want to determine if this hypotension is secondary to hypovolemia and monitor fluid status. Checking the tank allows us to do both of these things. In order to check the tank, we will assess the IVC. Typically, this utilizes the curvilinear probe, but the cardiac phased array probe may also be used. The probe indicator will be aimed towards the patient's head, as you can see there in the image on the right. And the probe will be placed in the subxiphoid region. You may need to adjust the probe somewhat to the right to find the IVC. So this is the ideal shot we're attempting to achieve. You can see that there's the liver there, the right ventricle, and the IVC. The IVC will appear as a long hyperechoic line that will typically have some variation with respiration. The right ventricle should be visible just to the left of the IVC on the screen. Take care to avoid assessing the aorta. If you're viewing the aorta, you'll actually see the aorta looping behind the heart as opposed to directly entering the right ventricle, which you'll see with the IVC. So once you get this lovely view of the IVC, you're going to be evaluating for collapse during respiration. There are complex ways to measure this. However, the simplest way is to estimate if it's collapsing more than 50%. For detailed instructions of these more complex measurements, I suggest the 5-minute Sono IVC review, and I will put a link to that in the notes below this episode. If the IVC remains relatively unchanged during respiration, it's time to search for another cause of shock and be wary of IV fluids in fluid-sensitive populations. So here's a lovely video from the fine folks at 5-minute Sono of a nice plump IVC. Note that the diameter of the IVC is not noticeably varying a significant amount during respiration. Now we're going to contrast this video with this video. And again, you can see this is a really nice catch of that right ventricle there. You can see the IVC going right in. Now you can see here with respiration, there's significant collapse in this IVC. This is a patient who can definitely tolerate more fluid and may certainly have shock due to hypovolemia. So back to our case 2, after performing a tush exam, you note great heart contractility, but a collapsing IVC. You resuscitate the patient aggressively with 3 liters of normal saline with improvement of vital signs. Her aspirin level returns at 84. You start a bicarb drip with potassium to alkalize her urine, and 2 days later, she is discharged to psychiatric care. High fives all around. So which toxins benefit the most from our tush exam? Tush exam can be particularly helpful with calcium channel and beta blocker overdoses, as these often result in decreased cardiac contractility and often won't respond to fluids, our sort of first line in hypotension. Identifying decreased cardiac contractility on exam with the appropriate history can help guide you towards the specific antidotes of glucagon and high-dose insulin. Lithium-poisoned patients tend to present with significant volume depletion. If lithium toxicity is suspected, rapidly identifying a collapsing IVC can steer treatment towards aggressive hydration, even in fluid-sensitive populations. For an in-depth review of lithium toxicity, please see the poison review link in this episode's notes below. And as the previous case demonstrates, aspirin overdose patients often present with volume depletion. However, there is a significant risk for pulmonary edema in these patients, so initial assessment of the IVC and further monitoring during resuscitation are essential, which our tush exam provides for us. So in summary, you want to use your tush exam in your tox patients with shock and hypotension. Remember, step 1, checking the pump, looking at that cardiac contractility. And number 2, checking the tank. Are they volume depleted? Can they handle more fluid? If you have any questions, you can find me at Dallas_holiday and dallasholiday@gmail.com. Thank you so much for watching. And here's a list of references if you would like to do any more in-depth reading on your own. Thank you.